Thanks, Victor, for the kind introduction, and good to see so many people who have joined us here today, and of course to those who will be joining afterwards in the recording. Thrilled to see that so many people are interested in using their spare time in hearing what we have to say about spinal pain. Now, this is, of course, a massive undertaking, the topic we've decided to focus on. And to be honest, we could probably prepare days worth of webinars, but still only touch on the surface. But we'll do our best, and hopefully we will have some good discussions later on. Now, the focus in this webinar is on spinal pain, because I think, as most people in here know, it is just a massive problem in the world. Now, I'm presenting you with some numbers from Denmark, which illustrate how much work absenteeism is caused by several common diseases, where you can see that spinal pain is topping the list. If we were focusing on use of healthcare services such physiotherapy or GP, it would be the same picture. Spinal pain seems to be topping the list all over. So it just goes to show that the problem is quite big. But worryingly is probably, however, more the tendency or the trends we see in the healthcare society. Now, the Danish Health Authority prepared a report published in 2023, where they predicted the future for the healthcare system in Denmark. But I am pretty confident that the picture is similar in other similar countries. Well, we can see that we're getting older and older, and this is, of course, probably because we have been very successful in managing and treating disease. So now we're getting older with disease, which causes some challenges and adds a bit of burden to the healthcare system, because all of a sudden we're getting older and older, and we're getting people that have a more complicated healthcare problem. Now, predictions indicate that if we want to provide the same level of health services as we do today, we will by 2040, so this is in 15 years' time, we will have to occupy pretty much everybody belonging to a youth generation in Denmark. And it probably goes without saying, the healthcare sector cannot just occupy everybody who will enter the workforce. So considering that we probably won't be getting more resources into the healthcare system, we are sort of forced to think alternatively, try to seek innovative ways to stratify care, but at the same time without compromising the quality or safety of patients. And this is probably the biggest motivation for us entering this consortium along with our partners in this Digi4MSK project. Now, to give you a bit of a picture of how our reality is here at Aalborg University Hospital, these are results from a small pilot study we conducted last year, where we asked people who are referred to us for because of spinal pain. We asked them to fill out the treatment burden, the multimorbidity treatment burden questionnaire, but it's a questionnaire that captures how burdened are you by the fact that you have disease or multiple conditions. Now, this is really important, because even though we, to the best of our ability, assess and treat the patient and develop what we can say, in our view, the best treatment strategy for them after discharge, if they are burdened by other healthcare conditions, their compliance to whatever good things we discharge them with, we probably won't have success with it, because it will be a barrier for them to take away all of the good things that we can provide them with. And we can see that a significant proportion of our patients are heavily burdened by other health conditions. And if we dive into the numbers, we can see that conditions like type 2 diabetes, cardiorespiratory symptoms, pain in other body areas. This is something that is present for a lot of our patients. So there is definitely a need for us to go and seek alternative ways of helping these patients. But it's also with the importance of creating space in the future healthcare system in mind, we need to do something different. And in this and in relation to that, I think it is really important that we look inwards, and this includes myself. I'm a physiotherapist by background, and if we just look at how healthcare services are provided today by physiotherapists, we can see that we have quite a big problem, because a lot of physiotherapists uh, uh, provide care that is not recommended in guidelines, and only a proportion of patient or physiotherapists actually adhere to guidelines and follow recommendations relating to what type of care do we provide, for example, patients with spinal pain with. Now, in the Lancet series published a few years ago, there was also a call for a change, especially with regards to reducing the provision of low-value care for low back pain. And some of the things they highlighted in their opinion paper was that we should stop using so much passive treatments, so manual therapy, prescribing too much rest or time off, try to reduce unnecessary repeated follow-up sessions with a physiotherapist or GP or chiropractor. That being said, however, I think it's very important for me to highlight that their recommendation related to the over-reliance of passive treatments and inappropriate use of manual therapy. This does by no means indicate that we should stop doing it, but instead we have to think really carefully about who should get it, when should they get it, for how long, and at what stage do we start tapering off and stopping treatment, because these are all very important elements to consider. Now, to be able to have that, take these things into consideration, we also have to understand the complexity of spinal pain as any other pain condition, because there are a lot of factors that can be important to consider when we're assessing and then managing our patients. And by using neck pain as a model, Stefan is going to give you some examples on how pain can present differently, even though it is related to the same region. Now, we're using neck pain as a model, but this could easily also apply to low back pain or thoracic pain, or for that matter, knee pain or hip pain. But I'm not going to steal all your thunder, Stefan. So I'm just going to give the stage to you, and you take it from here.
Thank you very much. So when we're talking about neck pain and how to manage it, we need to look at some of the recommendations. And if we look in Europe, there are a few guidelines that have kind of summarized what should we at least consider when we see these patients in clinical practice. And some of the things that have come up is we need to reassure the patient about their condition, that it's completely normal what they're feeling. Of course, we need to also ensure that it is, but once we rule out anything else, then we need to reassure them. We need to give them some advice and education about how they can manage their symptom, what they can do themselves. But we also need to give them some sort of either exercise or at least promote them to be physically active. And to give you an example of a case, a patient that I've seen in clinical practice, I would like to introduce you to Peter. So Peter has had neck pain for a couple of years. He describes it as sore when he pushes the muscles around the neck. And he describes that during daily activity, his pain will fluctuate anywhere between not feeling anything at all to 5 out of 10 on an NRS scale. And he describes the pain would get worse with some daily activities, especially when he uses his arms either to carry grocery bags or he used to go to the gym, but has stopped because when he was going there, he felt his pain was exacerbated. So these are some of the examples of things that are very common in many of these neck pain patients. But if we have to kind of summarize it to a few key points to look at further, it would be he feels sore in the neck, especially when he pushes on the muscle, and he feels increased or exacerbated symptoms when he's using the arms. So if we're trying to translate that into something that we can look at in the literature, we can say that looking at pushing on a muscle, that can be translated into assessing pressure pain threshold, meaning how hard can we push on you before you start experiencing it as more than a pressure, like becoming painful. And if we look at the literature on the topic, there seemed to be more or less agreement that there is a chance of having increased pain sensitivity and thereby reduced thresholds. And this seemed to be irrespectively if we're talking about idiopathic neck pain, like neck pain that's come without any specific cause, or traumatic neck pain. So we see this as something that may be a common feature in many types of neck pain. But if we look at exercise for Peter, that was a barrier because he felt pain. And that's despite that I've also presented that some of the guidelines says that should be something we should include. And if we look at the literature, it seems that exercise may have a positive effect on pain and disability over time. But the literature also seems to have no real consensus on a dose-response relationship, although there may be some indication that the more frequent you do exercise, the greater effect you will have over time. But even short durations of exercise may be enough. And some of the work that Professor Lars L. Andersen here from Denmark has done has shown that even a few minutes a day may be enough to elicit a positive response. However, when looking in the literature, there seems to be no consensus on what exercise is superior to another. So, in other words, it may be more important to get people to do something rather than do nothing. More so than they need to do a specific exercise to get better. However, when we compare like general exercise versus specific exercise, there also seem to be a bit of conflicting or contrasting findings in the literature. Some studies find that doing more general exercise, like sitting on a bike or similar, may be better in the short run, where others find that for the long run, it may be better to use some of the muscles in the area that you have pain. In total, you could kind of say that potentially we should more look at tailoring it to the individual. So what are they motivated for, so we can get them to do it more frequently and thereby elicit a positive response over time. For Peter, if we go back to him, he felt increase in his pain when he was doing exercise. And increased pain for those with neck pain when doing upper limb activity is actually quite normal. And that has been shown in quite a few studies. And one study by Osborne et al. From 2013 found that near 80% of those with neck pain will feel their symptoms exacerbated when they do some sort of upper limb activity. But how does this then relate to this increased sensitivity to touch, like the pain sensitivity we talked about earlier? We've done a previous study where we've looked at people with neck pain, both traumatic and idiopathic, and done a series of repeated arm movements. And what we saw was that the more arm movements they did, the more pain they felt. So that kind of fits with Peter feeling his pain increasing. But when we then measured the pressure pain threshold, we actually saw something quite interesting. When we looked at the healthy population, we could push on them harder before they felt it painful, so they actually got better. Where the exact opposite was seen for the idiopathic neck pain, which had a decrease, so we couldn't push as hard on them before it was felt as painful. And for the traumatic neck pain, it didn't really seem to change much, but that's probably more so due to a floor effect. Like they were quite sensitive already from the get-go, hence they could hardly become much more sensitive than that. But this is all on a group level. What is interesting, in if we start to look at individual data, we'll see that some of those with neck pain will have either an increased or a decrease, or even a mix, depending on which side we look at. So this, to me at least, means that we need to look at the patient in front of us rather than just relying on what the literature says on a group level. So we need to be interested in what do they experience and what do they believe about why they have neck pain. And to try and explore this a bit more, we did a study, which we're currently writing up, where we tried to figure out what did neck pain patients feel was the cause of their neck pain. And I've just taken a few examples here. So we had a healthcare professional. She woke up with neck pain a few months ago, and she experienced that she had tension around the neck and obviously pain, but it got worse when she felt stress at work. And she was quite worried about these symptoms, and she would have had quite a few differential diagnostic examinations. She's talked to quite a few healthcare professionals about these symptoms. And she had ended up choosing a treatment that was heavily influenced by manual therapy, and she avoided exercises because that actually increased her pain. And when we asked her about why she thought she had pain, one of the things she came up with was that it was the way she used her body, that there were certain ways that she had to use her body, otherwise she would be in pain, like certain postures, etc. But she also had a belief that she could feel that the manual therapy was actually helping her, that there must be something that was being put back into its place. But at the same time, she also had the belief that this probably wasn't completely fixed because the pain kept coming back, or at least was there uh, for for some time. So there was still something wrong. If we take another case, um, this was an office worker that had pain for several years, but initially had a similar history with more pain to begin with, had consulted quite a few healthcare professionals, but still ended up with the belief that exercise was key to management. What's interesting here is that um, when we asked him what he believed was the case, he also had this very biomedical belief that something was wrong, that some part of his neck must have been injured at some point. But then it also became very clear that he'd had a healthcare professional that had insisted that he took an active approach. And by doing so, even though it hurted initially, it was beneficial for him over time. So if we had to sum all of this up, we could say that we're all unique. Um, this means that we can't just look at what does the literature say on a group level. We need to consider what is the person in front of us telling us with regards to their pain. That it's we need to acknowledge that it's quite normal to have a flare up in pain when doing exercises, at least initially. That it is completely fine, but it would be helpful to stay active over time. So for Peter, that would mean that we would need to go back and talk to him about his experience, his beliefs, and thoughts about his neck pain. We would need to have a chat to him. What type of exercise would he be motivated for? And then together with him, find a plan that makes sense to him. For Peter, it was quite easy because he was very motivated of getting back to the gym. He'd just been afraid because it kept giving him pain. But once he was reassured that that was okay and it would go away again, he wasn't hurting himself. He was actually quite happy to go back to the gym. And I saw him only for a few sessions, and then he was completely fine and did fine on his own. So this, to me at least, underlines the very important fact that our words as healthcare professionals matters. And when we're then thinking of this like very individual approach, we also need to consider that when we're talking about self-management. So how do we approach that? And to elaborate that a bit more, I'll leave the stage for Tove.
Thanks, Stefan. Yeah, it was interesting because one of the things that we have investigated in this project, but something that I've also considered quite a bit in relation to my both my teaching role, but also in the clinic is, well, self-management, what is it? And I think everybody in here has an opinion on what is self-management. And I think almost everybody who works in healthcare would say self-management is an intricate part of my consultation. But it would be interesting to hear your thoughts on the definitions of self-management as they're presented in the literature. Because if we, and this is just a few definitions that I've hand-plucked from the literature, but by no means an emptying list. So you can see that there are many. I, of course, know that you can't read through all of them in such a short time. So I'm just going to summarize them very quickly for you. What they sort of collectively describe is an approach that focuses on patient empowerment, which probably means power to the people. It requires active participation, so it's not about lying back and waiting for something to spontaneously recover, but you actually have to do something. And it describes also a collaborative effort where the healthcare professional and the patient together design a strategy that is tailored toward the individual needs. Now, this is probably where it does get a bit tricky, because I presume not everybody considers self-management to be this. But this was also something that we found out when we started doing our study. So just to give you a small insight, what we did, we forensically investigated the available literature on the internet. We found 36 relevant studies, but our search strategy was tailored to help us answering these questions. So first of all, is digitally supported self-management better than standard care? Whatever standard care is, we'll come back to that later. We chose digitally supported because there is a lot of push for healthcare initiatives to go into the digital reality instead of being provided face to face. We found 27 systematic reviews, and we only included studies that had an outcome focusing on pain, disability, and health-related quality of life. But we were also interested in the sort of qualitative aspects of these interventions. So particularly, if self-management works, what is it that makes it work? And if it doesn't work, what is the barrier for it working? So why doesn't it work from the user perspective? Now, first, to answer the question, does it work? And actually, it does seem to do that. The majority of studies had results in favor of self-management. But we can see also that collectively, there are 11 studies that actually show mixed effects. So it might help on pain, but not on disability, or it might help on disability, but it was worse in health-related quality of life, etc. So it's a bit of a mixed bag, but and interestingly enough, also there was not really a difference between self-management strategies provided digitally or in a sort of face-to-face manner, or with a pamphlet, or a patient interview, or focus groups, etc. But what was really interesting and touching, getting a bit back to what Stefan was talking about with regards to exercise, it seemed like that a self-management approach, which was coupled to some sort of an active ingredient, so patient education and exercise, the active part seemed to boost the effect of the other part of it. So it was really, really, really interesting, and something that we can definitely discuss later on. But it was really interesting to see, however, and I think this is very relevant for us to consider, that in many cases, the comparator in the sort of control arm was very often, for example, an exercise or an education or advice, which was just provided in a non-digital manner. So you could consider that both the active group and the control group were getting the same. There were just different methods of providing these interventions. So on the one side, it's good to think at least, well, at least they're not worse, the digital approaches. But then again, you could also lean back and say, well, what's wrong with doing it the way we always used to? We'll leave it that until later on. Now, for the qualitative part, we found that to be effective, digital healthcare, digital approaches for self-management actually needed to fulfill quite a few criteria. You could see it had to be accessible, trustworthy. It should promote engagement and physical activity. It should also speak to people that were technically naive. It should be free of all ads. It should be individually tailored. And I'm pretty sure that you're thinking the same as I am. Is sort of, okay, this is all nice, but is this realistic with the resources we have today? And for this to be ever to become realistic, what needs to happen for that to occur? Yeah. I don't really know, but it would be an exciting exercise in trying to see, can we fit this into an approach that can be transformed to a digital medium. Now, coming towards the end of the presentation, I think it's very important to highlight that self-management does not equal you need to manage yourself. It is really, really important that people in clinical practice have different needs, and we need, as healthcare professionals, to be equipped in identifying who will need a lot of help and support and who can make do with less. But the key thing here is, coming back to the definition of self-management, it is a collaborative effort. Okay, it's not just the healthcare professional writing up a set of exercises and sending the patient off. It does actually require, in some cases, follow-up and continuous engagement to varying degrees. Okay. And just to give you a short example of this, we did conduct a study, which we are currently writing up, where we interviewed patients that had gone through the management procedures here at the hospital and had been discharged and sent home with a set of exercises. What we were particularly interested in was seeing or investigating were the barriers and facilitators for home-based exercise. So what is it that makes it good, and what should be done differently in the future, perhaps? And what we could see sort of collaboratively for the patient responses was that, well, they really, they felt that a follow-up of some sort, or somebody checking up on them and seeing everything was going okay, was considered very reassuring, and providing them with some certainty that things are actually going into the right direction. It helps eliminating a lot of the uncertainty people might have with regards to, am I doing it correctly? What does it mean if my pain gets worse? Is it okay that I'm a bit sore afterwards? All of these things can be cleared in a consultation. That being said, however, I think we need to be very mindful of, and again, something that we can probably discuss later on is, does this sort of support, does that require a face-to-face interaction, or can we use digital medium like an online consultation or an email or a text message? Because I think a lot of support can be provided that is actually also helpful without seeing the patient one-on-one. Now, just to conclude and finish up, there are very many ways of providing good value healthcare. It doesn't only mean face-to-face consultations. But what's really important, be it digital interventions or face-to-face analog old school interventions, they need to cater for the individual needs. And this might pose some challenges for digital approaches, especially those that in the future will to some degree rely on artificial intelligence and use treatment and assessment algorithms to define the needs and the treatment pathways for the patients. And the last thing that I want to highlight is that all pain, and this includes, of course, spinal pain, is multidimensional. Stefan touched a bit on that as well, talking about worrying and uncertainties, etc. And the self-management approaches need to account for this. So exercise is an excellent medium, perhaps, to support self-management or as a part of self-management strategies. But I think it's really, really important that we as healthcare professionals always think, what is the purpose of the exercise? Is it always the patient that needs to get stronger, or can we use exercise as a tool to provide security and build resilience and build sort of faith in their own ability, etc. There are a lot of things that we need to consider, but it always comes back to sort of what does the patient actually need. Now, thanks a lot for the attention. I look forward to a talk. I just want to kindly remind you and ask you to follow our project. We are on all of the social media platforms that are available, I think. Even the platforms that I am too old to be involved in. Yes, thanks, guys. See you in there.